Okay, so we will proceed with Dr. Marian Polly, and she will be talking on inflammations of the orbit and overview. So we will be starting with her session because she has to go for her finals as well. So best of luck for that, ma'am, and over to you, ma'am. Ma'am, it's open over here. Yes, ma'am.
Good afternoon all. Good afternoon. At the outset, let me thank Dr. Fairuz for giving me this opportunity. I'm sorry, since I have to go for another session, I'm starting with the topic. My topic is on orbital inflammation and overview. So why orbital inflammations are important? So here is a 23-year-old female who is a known case of deafness who had already undergone tympanic membrane biopsy. Turned out to be non-specific inflammation. Presented to us with features suggestive of left dacryadenitis. Visual acuity in the left eye was 6/18. Fundus showing choroidal folds. CT scan, you can see diffuse inflammation involving the lacrimal gland as well as the superior rectus and the lateral rectus, causing indentation of the globe. And since she has already been treated with steroids and antibiotics from elsewhere, we directly did a biopsy and turned out to be granulomatosis polyangiitis or vaginous granulomatosis. And she was treated in association with the rheumatologist, and she became all right with the injection rituximab, and she is currently under follow-up. So so when you speak about orbital inflammatory disease, this is very, very important for all of us because every day and every week we come across lots of inflammations, especially in the post-COVID era. And the classification is based on etiology or pattern of involvement. It can be either specific inflammation or non-specific inflammation. Non-specific NSOI, that is non-infectious, non-neoplastic. Then this disease can be either diffuse anterior or posterior inflammation, can be localized, that is the target organ, either muscle, that is myositis, lacrimal gland dacryadenitis, then apical inflammation or perineural inflammation. Diagnosis is essentially based on the clinical history and examination. Here, one thing I wanted to stress upon is, apart from the routine features of swelling, redness, patient can present with chronic retroorbital pain, that is chronic infections can mimic inflammations, especially tuberculosis. So then comes the role of radiological investigation. CT scan will give a clue to the extent of involvement as well as any element of bone erosions. Then comes the investigation. This is the panel of investigation which we do in cases of recurrent orbital inflammations, basically to rule out vasculitis, sarcoidosis, granulomatous inflammations, vaginous granulomatosis, tuberculosis, and IgG4. So this is a patient, she's 54-year-old, chronic diabetic with a recurrent fever and history of chronic pains in 6 months and occasional diplopia. So now you can see the CT scan showed an apical inflammation. Her Mando was strongly positive and she was treated with ATT and she became all right. This is a 45-year-old male with retinal redness, treated as scleritis from elsewhere, orbital inflammation from elsewhere. CT scan showed a muscle enlargement of the medial rectus with surrounding fat stranding. So is it inflammation? So now the question comes. But here the single muscle is involved, which is almost more than 10 millimeter. So we suspected lymphoma. We did biopsy and turned out to be a mantle cell lymphoma. But look at the radiologist report. Reported as orbital pseudotumor or thyroid ophthalmopathy with differentials like lymphoma or metastasis. So as ophthalmologists or oculoplasty surgeons, we should be able to read our own CT scan rather than to depend on the radiologist alone. Similarly, this is another patient, 50-year-old female with a recurrent lid edema. You can see element of mild lid edema, and there is inflammation in the temporal and the inferior quadrant with the limitation of ocular motility in the up gaze and down gaze. CT scan showed muscle enlargement. Here the characteristic feature is you can see a scalus. So this is a case of cysticercosis. So each patient presenting with inflammation, we have to rule out chronic infections before treating with steroids alone. So coming to the management, steroids form the first line of treatment. Either systemic steroids is the mainstay of treatment. Can give intraorbital steroids after ruling out steroid response. Then comes the immunosuppression. Immunosuppression always we prefer to do along with the help of a rheumatologist, because each disease the immunosuppression depends on multiple factors, disease, then comorbidities and the age of the patient. Then comes orbital radiation, especially in sclerosing orbital inflammations. Then comes the role of surgery. We'll see one by one. So now come to the role of biopsy. It confirms the diagnosis. Second thing, you can diagnose the specific etiology, especially granulomatous inflammations like sarcoid, GPA. Then another entity is IgG4 related disease. All this disease has got a specific histopathology criteria to diagnose. This specific diagnosing a specific etiology is very, very important, as it can have systemic involvement, and the prognosis also depends on prognosis and treatment depends on the specific treatment also. Then rule out mimickers. So now again, if you speak about the role of biopsy, it debulks the tissue in fact. So this is been reported in idiopathic dacryoadenitis. This journal this is published in Ophthalmology 2020. Here, especially in cases of idiopathic dacryoadenitis, when the patient has got multiple recurrences, the moment you taper steroid, it will recur. In that case, in fact, you undo a biopsy, which will give you a clue to the diagnosis as well as it debugs the tissue, so that the substrate for inflammation will be less and it gives cure also. So now come to a pediatric case. So this is a 11-year-old child presented to us with a recurrent lid edema, was already been treated with oral antibiotics from elsewhere. So you can see the CT scan, there is an inflammatory mass involving the lateral orbit with bone erosions. So we took him for biopsy and proved it as Langerhans cell histiocytosis. He improved with intraorbital steroids and became all right. So when you treat orbital inflammation, we have to really very, very careful. Are we treating anything else? So this is a 68-year-old female presented with the swelling right eye since 3 weeks. Right eye vision is 6/18 with a relative afferent pupillary defect. You can see there is lid edema is there, chemosis is more inferior. Can put first diagnosis as orbital inflammation. The other possibilities like CCF and thyroid eye disease. Now look at her CT scan. So even though you can see a dilated superior ophthalmic vein, here look at the radiologist report. If you see, there is an extracorneal fat stranding in superior orbit with prominent vascularity. Right superior ophthalmic vein appears dilated within the right orbit, suspicious for inflammatory etiology. So it was treated as orbital inflammation, but it was indirect CCF. Patient was referred to the neurointervention and she became all right with intervention. So we have to roll out all the mimickers. Now a word about the lacrimal gland. So this is a 52-year-old lady presented with bilateral lid swelling. So you can see both the lacrimal glands are enlarged. CT scan also confirms. So in bilateral lacrimal gland enlargement, we did a study, almost 30 to 40% will have a specific etiology. So when you see a bilateral dacryoadenitis, keep a low threshold for biopsy as in bilateral involvement as well as in lacrimal gland with diffuse orbital involvement. Then mimickers, the another thing is we have to rule out metastasis and malignancies. So this is a 61-year-old female presented with lid edema since 8 months, treated in multiple places. You can see the scan, there is an ill-defined mass. Biopsy proved it as metastasis from severe breast, and she was treated but succumbed. This is again another patient, 18-year-old. Here all the age group is very different. That is also a clue that it is not real orbital inflammation. He had a prostate with metastasis. The another close mimicry is differentiating orbital lymphoma from orbital inflammatory disease. That is also very, very important. So to conclude, orbit is always a Pandora's box. Treating inflammation, we have to be very careful. You should know the whole medicine, I would rather say. Proper treatment and is always very rewarding. So with this, I would like to invite all of you for the national conference, that is 6th Annual Conference of Oculoplastic Association of India on April 24 to 26 at Kochi. Thank you.
Thank you so much, ma'am. And we wish you all the very best for your session. We won't delay you because we know that you are required to. We won't delay you because we know that you're required to reach there.
Thank you.
Thank you, ma'am. Thank you so much. Next, we have with us Dr. Tarjani Dave, and she'll be talking on orbital infections, common and uncommon. Over to you, ma'am. Can somebody help her put the...
Am I not audible? I am okay. This is very disturbing because I can't figure out if I'm audible or not. All right. So, thank you, Fairuz. Thank you, Rolika and Seema. And I think my job is fairly easy. It's on a very easy topic of orbital infections. And I thought I'll bring to you certain things that sort of should be on your checklist as you're treating orbital infections. We'll go through these objectives that I've listed here. I wanted to show you some atypical cases as well. How do you treat a typical bacterial cellulitis? How has the microbiologic pattern changed in India? What should be your empiric antibiotic strategy? And some complexities like compartment syndrome, SOV thrombosis, and a little bit to touch upon fungal cellulitis, because we're the diabetic capital of the world and we definitely see more fungal infections than anywhere else. So certainly should be on your radar while you're treating infections, and a few masquerades that you should also be aware about. I have no financial disclosures, and you will see some full face photos of my patients for which we have the consent in place. This is a very, very old slide from L.V. Prasad Eye Institute, probably from the time when Seema was a fellow, with one patient showing the very classic typical orbital cellulitis with an abscess, and this actually is a hydatid cyst. It's a parasitic infection of the orbit. So if you just were to look at the exterior, it would look very similar, but underlying treatment and the way you evaluate the patient is diametrically opposite. So this is something that you should have in mind. Now, how does your typical red hot orbital cellulitis look? This is how it looks. It comes from the sinus, and therefore on imaging you will see ipsilateral sinus haziness. Your red flags are when vision goes down, when there is RAPD, and when there is severe ophthalmoplegia. Many times assessing vision becomes difficult, and therefore these measures of looking at the pupil sort of aid in you getting a guesstimate on what the vision is likely to be and whether the optic nerve is involved or not. CT remains the investigation of choice, and you want to see the paranasal sinuses because that's where it's coming from in most cases. And you treat these patients with IV broad spectrum antibiotics for about 48 hours and then introduce steroid, because by then it's just the toxin and inflammation and the infection has actually died down, and you'll see a dramatic improvement in the condition. But what happens in situations like these? So this is a child just about 3 months old who has undergone endoscopic surgery for laryngomalacia and has stridor, and you can see that this child has severe orbital cellulitis and is being actually treated with a very high-end antibiotic, which is piperacillin with tazobactam. But will this antibiotic alone lead to resolution? No. Why? Because in this cellulitis, you can see these abscesses that have formed. These encapsulated abscesses do not allow antibiotic penetration, and therefore in situations like these, you need to actually go and drain, or even just put in a large bore needle like an 18 gauge needle over a 10 cc syringe and aspirate those pockets of pus, and that will lead to a much quicker resolution, and you may not even need to start very high-end antibiotics for such children. Always look on the scan for these ominous little gas bubbles. This is from an anaerobic infection. I've listed out the gas producing organisms. It's not rare to see these infections in the orbit. When you see these sort of bubbles, you're thinking of two things. One, if it is bacterial, it's probably an anaerobic infection, and if it is a fungal, then it's largely a necrotizing infection, which means that particular dark area is necrotic and dead tissue, and just like necrotic and dead tissue or gangrene anywhere in the body, it needs to be removed. So these are things that you should pick up on imaging. Now, this is the typical microbiology. It is a little different between children and adults, and I've divided it into less than 10 years, 10 to 15 years, and over 15 years. And as you see, older children and adults tend to have polymicrobial infection, and they may also have anaerobic organisms. So that suspicion should be there when you're treating this subgroup. Versus that, in children, you largely tend to see a single organism, aerobic, largely a strep or a staph, sometimes Haemophilus infection, which is easily treatable by your run-of-the-mill antibiotics. And here I've listed the antibiotic strategy that you should use. What we tend to use in our practice as first line is Augmentin IV, which is started for 48 hours, after which steroids are introduced if you're very sure that this is just bacterial infection. And then you have other second line and third line antibiotics that you can introduce once you move from the empiric to the known stage of the infection, that is when your microbiology results are out. Few other complications that you should be aware about. Now, this is an interesting situation where you know that the orbit is pyramidal and it's like a box, right? And things can enter in, but going out sometimes becomes difficult, and that is where you see a compartment syndrome. On imaging, this is like a guitar pick. So if you see the posterior end of the eye, you can see the tenting there of the ocular cords like the pick of a guitar, and this means that there's so much pressure in the orbit that it's actually compressing the optic nerve there, and this can lead to vision loss very rapidly and needs to be reversed by an immediate canthotomy, cantholysis if possible, and orbital decompression, and bombarding the patient with IV antibiotics and starting steroids sooner than usual if this is a compartment syndrome from a bacterial infection. And that is what was done in this gentleman, and after the edema resolved, we figured that it was actually a pando that had produced orbital cellulitis with compartment syndrome, and he needed a DCR. The other thing on your mind when you start and follow up on therapy and you see that the chemosis is not really going down, the eyelid edema has gone down, but the chemosis has not, go back and image again. You'll be surprised that sometimes you see a superior ophthalmic vein thrombosis. This is an enlarged superior ophthalmic vein with the black inside showing you the thrombus there, which is what can happen with certain infections. And these are situations where it can progress to a cavernous sinus thrombosis as well, and you may need to introduce antiplatelet agents along with an immunologist or a rheumatologist. You need to continue aggressive IV antibiotics along with anticoagulation in certain select cases. Briefly, we look at fungal infections, and these can masquerade big time. You can have a fungal infection look like an NSOID or like a tumor or sometimes like Tolosa Hunt. There are certain telltale signs. If you see bone destruction or sometimes osteomyelitis, which appears as thickening of bone, or cutaneous fistulas and necrosis in a patient who is, say, a diabetic or immunocompromised, then it points more towards a fungal infection. So I'll just take you through the two common infections that we see, and on your One side, right or left, I can't figure out, is mucor, and the other is aspergillus. Now these are two distinct orbital fungal infections. Mucor is fast and you have to be very, very quick in treating it. It has a biological behavior of angio-invasion. So if infection is in the sinus, by angio-invasion even the brain can get involved without the orbit getting involved in between. Versus that, aspergillus is a little slower and more like a granulomatous inflammation. In mucor, death can be as high as 50 to 60%, and therefore urgency in diagnosing and treating with amphotericin B is important. In aspergillosis, the mainstay of treatment is essentially voriconazole, which can be injected in the orbit or even can be given as oral voriconazole. Here's a lady with a sino-orbital lesion. Biopsy turned out to be aspergillosis. I'll be very quick, and was treated with voriconazole, and you see that resolution. Versus that mucor that progresses in days to ophthalmoplegia. Again, we were able to reverse it by removing the necrotic tissue and injecting amphotericin B in the orbit. Also, sinus debridement plays a big role. Certain times you may have things like this where you don't know it's a tumor or an infection. You biopsy, you send for micro, you send for path. This was actually actinomyces. So this is when infection looks like a tumor. Sometimes you may have situations like this where this lady was treated for thyroid eye disease. But if you actually don't look at her MRI and look at CT scan corresponding cuts, you'll pick up bone destruction and a sinonasal lesion. We went in, biopsied. This was again aspergillosis, treated with voriconazole, and it resolved. Sometimes you may have a mass that looks like an orbital infection. Biopsy turned out to be CA maxilla and treated with radiotherapy. Again, something that looks like a bad infection in a young lady. She's HIV positive, bilateral sinus and orbital involvement. Biopsied and turned out to be a large cell lymphoma. So in essence, I've spoken to you on these topics of typical bacterial cellulitis, the vision-threatening complications that come with it, especially compartment syndrome, superior ophthalmic vein thrombosis, the microbiology spectrum across different age groups, and what's in your repertoire for treating with antimicrobials. Briefly touched upon mucormycosis and aspergillosis and showed you certain masquerading cases that you should be aware about so that you always biopsy when you are in doubt. Thank you so much, and inviting all of you to the AP Sopras meeting at the end of this year. Thank you.
Thank you, Tarjani, for highlighting these very important points. Infections are a very vast topic, and these practical pulse are something which are going to be really useful for the audience. So since we are running short of time, I think we'll continue with the session. And next speaker is going to be Dr. Senthil, and he's going to talk about orbital trauma, the management pulse. Over to you, Dr. Senthil.
Sir, audio with you? Lose contact, huh? Would lose contact? It's coming back. Okay. Yeah, good afternoon, everybody. So today I'm going to speak to you on the management protocols for orbital fractures. I'd like to thank Fairuz for this opportunity. And we all know orbital fractures are very commonly encountered in our clinical practice. And I will not dwell into the types of fractures and the mechanism. I'll quickly go to the clinical presentation, how to approach a case of an orbital fracture when they present to us. So one of the common presentations they come with is with restricted motility. So that is one of the common clinical findings you have to look for. When a patient with an orbital fracture complains of double vision or restricted motility, that is a red flag that something is wrong. Most probably they have an entrapped extraocular muscle, and you need to investigate them carefully because that is an indication for surgery. So the common clinical features is they have enophthalmos, they have hypophthalmos, they can have hyposthesia, and you have a special a variant called the white-eyed blowout fracture, where the patient has got a completely white eye, usually in the pediatric age group. They have a white eye, but they'll have significant bradycardia, vomiting, and if you do a CT scan, you will pick up a entrapped muscle. So it's very important to identify that. And mainly coming now, when will you operate on these patients? When will you operate on a patient with an orbital fracture? The two common indications are if they have a entrapped extraocular muscle, which you confirm on a CT scan and on a force suction test, or if they have significant enophthalmos greater than 2 millimeters. So these are the two common indications when we'll operate on patients with orbital fractures. So it's very important for us to image these patients. Any patient with orbital fracture, you have to image them carefully, and the imaging modality of choice is a CT scan, not a MRI, because you need to see the bone, you need to see the entrapment, and you need to see the muscle which is entrapped into the bone. So MRI will not give you such bone details. So it's important for you to do a CT scan, and always do sagittal, coronal, and axial cuts. So you can see this patient has got a fracture but not significant enophthalmos vis-a-vis this patient who's got significant hypophthalmos enophthalmos. So coming to the preoperative workup, you do a basic vision screening and all the normal anterior segment evaluation, and you do a force suction test wherein you anesthetize the patient and you just gently pull on the globe and see if there's any resistance to extraocular movement. And on force suction test, if you find significant restriction, then most probably this patient has got entrapped muscle and you will need to intervene. And like I said, CT scan is very important modality, and you do all the different cuts. Sagittal cut is again very important because you need to see the posterior extent, you need to see if they've gone bone posteriorly so that you can place the implant. And initially, all these patients don't need to be treated surgically unless, like I told you, there's significant entrapment, or if they have a white-eyed blowout where you need to release the muscle immediately. So initially, you do medical management, you put them on systemic steroids, antibiotics, wait for 5 days to 1 or 2 weeks, and see if there's any improvement in the double vision. If there is no obvious entrapment, sometimes the adjoining fat or the soft tissue can be entrapped without the extraocular muscle being entrapped. If that is the case, they will improve. But if there is no improvement, patient is complaining of double vision, then you proceed and go ahead with surgery. What are the different approaches? Either the transcutaneous or the transconjunctival. The transcutaneous is not preferred because of obvious reasons. You have significant scarring, you can have keloid formation, and the patient responds badly to the incision. So the transconjunctival is the preferred mode of choice, and this is a video of the transconjunctival. So basically what we do is you make an incision infratarsally. So you invert the lid, make an incision in the intratarsal area, and then you go in front of the septum without opening the septum. So you do a preseptal dissection, and you reach the inferior orbital rim. And once you have reached the inferior orbital rim, so what you have to do is you have to make an incision in the inferior orbital periosteum, and then go underneath the periosteum, lift all the contents, wherein you reach the floor. And once you have reached the floor, you identify the margins of the fracture, release all the entrapped extraocular muscle and the soft tissue. And once you can identify the margins of the fracture, you place an appropriate implant. So if the fracture is not very large, and if they have significant bone remaining anteriorly and posteriorly, you can place an implant which need not be fixed. But if they have a large fracture and the posterior ridge is not there, then you have to place an implant which needs to be fixed to the anterior maxillary rim. So this is a Medpore implant, so you can cut it and place it to the, size it, and you can put it into the floor. So that's the implant which is being placed. And you have different varieties of implants. You can use autogenous bone, rib cartilage, ear cartilage. Alloplastic is what we prefer, like titanium, silastic, porous polyethylene, and even etiosterilized X-rays, bioabsorbable. All these are different implants. And autogenous, usually we don't prefer them because of the donor site morbidity, and titanium is what we usually prefer. These are the older generation titanium implants, the sheets which were there, and then off late we have the contoured implants with extensions where you can fix the implant. You have the combined implants, and this is the plating set the micro screws, the drills with which you can anchor the implant. And this is how you, these are the micro screws, and once you have placed a titanium implant which needs to be fixed, you can actually, you have the self drilling screws where you don't need to actually use a drill bit. It just goes directly into the bone, and with that you can fix these implants beautifully like that. So this is the only titanium implant. And sometimes what we prefer nowadays is we prefer a Medcore ported titanium. This is the previous generation which has channels through which you can put the titanium plates. And this is the combined Medcore titanium implant called as the Titan implant. And basically what we do in this implants is it has a coating of Medpore on top of the titanium. So the metal is not exposed to the soft tissue, because the metal can have small pores through which the soft tissue can get entrapped. And also the Medpore also is not exposed, that has got a smooth lining. So this is one of the best implants. So it's a double barrier Medpore coated titanium implant, which is very, very biocompatible, and results are very good. And the one more variant is the bio reabsorbable implant, which reabsorbs in a few months' time. And if the patients are not very affordable, you can use the X-ray film, which you can ETO sterilize. If it's a small fracture, this will work well. And these are some of the videos. So you can see this patient has got a white-eyed blowout fracture of the left eye. You can see when he looks up, there's no elevation at all. And this is following surgery. You can see there's a complete restoration of the extraocular motility through a transcontinental approach. And again, one more video where you can see this patient has got an entrapped medial rectus. So you can see on horizontal adductions, there is a significant restriction. And via a transcaruncular approach, you can see again the patient has done quite well with a full and free extraocular movement. And these are again, some patients you will need to use multiple implants, and post-operatively you have to be careful. You have to place the implant correctly and close the soft tissue, otherwise you can have wound-related problems, implant extrusion, dislocation, etc. And putting an implant, you should never take it lightly. You can have implant exposure, you can have implant migration, and a lot of other issues. So in conclusion, orbital fractures are very commonly encountered in a clinical practice. If you identify these patients and operate on them at the correct time, you can have excellent results. Again, thank you once again for this kind opportunity, and thank you again. Thank you.
Thank you so much, sir. I think you did a great job in explaining all the intricacies of ocular trauma, and also the post-op results were great, sir. So congratulations to you. Thank you, sir. And we will move on to our next speaker. Thank you. Do we have Dr. Fatemeh Rajai with us? Okay, so our next speaker is Dr. Seema Das, and she'll be talking about proptosis, which are the steps to open the Pandora.
Thank you, Rolika, and thank you for Feroz for this invite. And my topic is to talk on proptosis, and I know the audience here seems to be mainly oculoplasty specialists. So I don't know what to speak on proptosis evaluation to all of you, but let's this be a revision. And if there are any fellows or residents sitting here, maybe something for you to take back. So step by step approach to open the Pandora's box. And when I asked Feroz what I am supposed to talk about, is it like how to do an orbitotomy to the approaches, she told me specifically don't talk about surgery at all. Idea is to talk about how to approach if we find a case of proptosis in our clinics. So what we have to understand to begin with is proptosis is not a etiological diagnosis. It's just a common sign of a diverse set of pathology, which could be infection, inflammation, all of which we just saw. So it's very important to have a methodological evaluation to analyze each case to get the etiological diagnosis. And the etiology can be anything, right, from infection to neoplasms, and the symptoms and signs could be anything which affects any structure of the orbit, whatever structures are there, right from vision loss to pressure effects, to proptosis, to mass lesion, anything can be there. So how do we go about analyzing this case, and what are the goals of our evaluation? So first thing, we want to know what is the diagnosis, and we want to know how do we manage those cases. So that remains our goal, and with this approach we are going to go stepwise. The step one always remains history and evaluation, which we tend to forget sometimes in the clinics, and we tend to hurry up. But I think the majority of the diagnosis, if we go for a good history and a good examination, we will end up getting or narrowing down our differential diagnosis to 2 or 3, and that's what is the whole idea. Once we narrow down to a differential diagnosis, if needed, we go for imaging, which is going to refine our differential diagnosis further, or sometimes give us the definitive diagnosis. If even the step 2 is not working, we go to the step 3, which is biopsy and other investigation, which more often than not, most of the time, will give us the definitive diagnosis. That's our final diagnosis. So before we even start, we must remember that there are something called as pseudoproptosis, like a patient of high myopia, the enophthalmos in the other eye, any ophthalmos, anterior staphyloma, they all can look like proptosis, but there is nothing wrong in the orbit. The problem is in the eyeball, and that should not be we should not forget about it. So we start with the step 1, which is the patient history, and sometimes age of the patient can give us a clue what we are dealing with. And if we see in the newborn or in the infancy, most common orbital lesion could be a capillary hemangioma, which is there in the first child, but sometimes there can be the sinister ones also, the second child who has a rhabdomyosarcoma. Lesions in the early childhood, like the first one, likely to be infective inflammatory, especially if it's a rapid onset, but we should not again forget about the neoplastic etiology also. The second child had an Ewing sarcoma. Young adults, bilateral proptosis, more likely to be thyroid if the other ancillary signs are present, and you can have other infections like a parasitic infection also which can present, and when you go down to the old age, we are more likely to deal with a neoplastic etiology. Come on to the duration and the progression of the disease. This is again something which can give us very important clue to formulate a differential. Something which is very catastrophic presentation within a matter of hours is likely to be a hemorrhagic cause for the proptosis, which could be bleed inside a lymphangioma, which is a relatively not so serious disease in terms of repercussions on the life, but it has repercussions on the vision and the glow. But other neoplastic diseases in a child, like bilateral hematoma, periocular ecchymosis, can also be a manifestation of a metastatic neuroblastoma and should not be forgotten. Things presenting in days likely to be inflammatory or infective, rarely neoplastic, like the second child has rhabdomyosarcoma presenting with a lot of orbital inflammatory signs. Weeks to months, again more likely to be, especially if it's in the older age group, could be a benign or a malignant neoplastic pathology depending on what we are dealing with. And if it is in years, it's most likely a benign cause like a dermoid cyst, or maybe a very slow growing benign lesion like a cavernous vascular malformation. Direction of the displacement again is something which can give us a clue what area of the orbit the pathology lies in, and that can help us again to formulate a differential. So we need to understand the concept of axial versus abaxial proptosis. If the lesion is lying in the posterior orbit, an intraconal location like a cavernous hemangioma in this young gentleman is likely to be an axial proptosis. The more anterior the lesion is, if it is not in the intraconal but in one of the extraconal areas, it is going to cause an abaxial proptosis. And the direction of the displacement of the globe is going to be opposite to the direction where the lesion is there. So if we just see a globe which is down and in, we know that we are dealing with something which is in the superolateral orbit, and the most common location there is likely to be lacrimal gland lesion. And of course, we have to look at the other associated symptoms, and eventually that's what is going to help us get a differential diagnosis. Going on to the examination, it's same as examination which is done in for any other medical disease, and which we all have read in the medicine books. We see the local area, the regional, the face, periocular area. We do the examination of the eye and the visual functions, and we do a systemic examination. And the algorithm remains the same. Inspection, that is, look at the appearance of the lesion. We palpate if there are any nodules or mass. Percussion is something which probably is not very relevant for the orbit, but we do auscultation once in a while. Sometimes we do need a stethoscope, otherwise we have almost forgotten where our stethoscopes are to detect any bruit or thrill for any AV malformations. Regional examination again can be a big clue to the diagnosis, like a subtle temporal fullness or a maxillary fullness can tell us that we might be dealing with the maxillary sinus pathology with secondary involvement of the orbit. Lymph nodes are extremely important if we are dealing with malignancy. Sometimes the skin evaluation can help us find the cafe au lait spots, which makes the diagnosis more towards NF. And in a patient, elderly patient, especially immunocompromised, presenting with a sudden onset proptosis, vision loss, looking at the palate is extremely important because, as Dr. Tarjani just mentioned, mucormycosis is something which can also be an important cause of infection in the orbit, can also have palatal involvement. Pericolar evaluation, again looking at the color of the skin, looking at some fistula, lid lag, these are again things which can, even without touching the patient, we can get a clue to the diagnosis. There are some special maneuvers sometimes which we do in proptosis patients, something like Valsalva maneuver. We know that if the proptosis increases with or the enophthalmus becomes better, eyeballs comes to the normal position, or the proptosis increases with Valsalva, we might be dealing with a varus or a veno-lymphatic malformation where there is a predominant venous component. This was a very interesting patient who had a dumbbell dermoid going into the temporal fossa and pushing the eyeballs. Every time he used to kind of chew because of the pressure of the muscles, the temporalis muscles, the eyeball used to move forward. So chewing induced oscillopsia is something we are aware about it, but it can also cause something like a pulsatile proptosis. Transillumination tells us that we are dealing with a cystic lesion, can sometimes help when the differential diagnosis, especially if you have to rule out any orbital mass lesion in a child presenting with a lesion like that. Palpation, again, if there is an orbital mass, we again follow the same protocols. We kind of see the size, shape, location, feel, surface, everything. Resistance to retropulsion gives a clue what kind of pathology it might be there. Is it a benign or something which is infiltrating where there is likely to be resistance to retropulsion? Pulsation, especially in caroticocavernous fistula, that is again something which can elicit on palpation. Visual function extremely important because any lesion in the orbit can have secondary effect on the visual function, or sometimes the lesion itself can be arising from the structure responsible for the visual functions. And we can get important clue like the secondary effects in the form of retinal and the chororetinal folds, optic atrophy, which sometimes are the secondary effects of any orbital mass lesion. Sometimes a slit lamp evaluation can give us a clue to the diagnosis of a caroticocavernous fistula where the very subtle pulsatile proptosis might not be evident, but while doing the tonometry we can see the Meyer's pulsating, and that's how we can pick it up. Finding the leash nodules in the iris confirms a diagnosis of neurofibromatosis, so we must not forget our slit lamp that we are ophthalmologists, we should get into the habit of slit lamp evaluation also, even if we are oculoplasty specialist. And many a times the clue actually can be lying in the anterior segment or the posterior segment evaluation. Like if you see these optociliary shunt vessels in a middle-aged lady who presents with a proptosis, we know that we might be dealing with a meningioma. That's almost is a short sign of many of those optic nerve sheath meningiomas. Finding rod spots in a child with a rapidly progressing proptosis almost confirms the diagnosis of a leukemia. This child was interesting. He almost did not have apparent proptosis, very subtle prominence of the eye, but he had more of visual function which was affected. And on evaluation, we found that this swelling of the optic nerve head with peripapillary changes and a very subtle thickening, diffuse thickening of the optic nerve eventually confirmed to be an optic nerve glioma, which was very atypical. Measurements remains the next step of the evaluation. Hertel's exophthalmometry remains the gold standard of documenting the amount of proptosis and on following up. But we should know that Hertel's is applicable only for axial proptosis. If it's an abaxial proptosis, we must also measure the amount of displacement, horizontal as well as the vertical displacement, by kind of putting a scale or drawing those reference line and measuring the amount of displacement and comparing it with the normal eye. Systemic evaluation can't be forgotten. This lady who comes, elderly lady, comes with a proptosis, and when she gives the history that she has some neck surgery a few years back, there was a scar in the area of the thyroid. A thyroid surgery was done, which possibly was a malignancy. And when she comes with this proptosis with a mass in the orbit, we know that we are probably dealing with a metastatic carcinoma coming from the thyroid to the orbit. Those small neurofibromas, cafeolar spots, diagnosis of again suggestive of a neurofibromatosis. Step 2 remains imaging. I am not going to the details of it. That is probably beyond the scope of this presentation. But based on our clinical evaluation, we decide whether the patient needs a V scan or MRI or a CT, and whatever is appropriate, we advise that. And if imaging also is not giving us a very conclusive diagnosis, we go for biopsy, so which should be giving us the final diagnosis. So just looking at few case scenarios, just to illustrate how these 3 steps can help us arrive at the diagnosis. So this was a young gentleman, bilateral prominence of the eye, lid lag on down gaze, some signs of inflammation of the eye. With all this clinical evaluation, we know that we are dealing with a thyroid eye disease patient. We don't need any evaluation, any imaging to confirm the diagnosis. Imaging is required only if we are planning maybe some surgical intervention to the orbit. And these are the patients where the treatment can be started straight away based on your clinical evaluation, and they respond pretty well to steroid if the treatment is started for the active phase of the disease. Another young girl comes with a sudden onset proptosis with signs of inflammation, displacement of the eyeball, congestion of the conjunctiva, and we see a nodular thickening in the inferior fornix. With this very sudden onset presentation with not too much of pain in the eye, in our setup we know cystosarcosis is something which is very endemic and can present with a sudden onset proptosis, movement restriction, which does not follow any pattern. So that's the key. But we have to confirm the diagnosis. We go for an ultrasound, which is good enough to confirm the diagnosis, and we can start the treatment. So here step 2 gives confirmation of the diagnosis. We don't have to go and biopsy this lesion. And there are situations where despite everything, despite imaging, this gentleman unilateral proptosis, other eye absolutely okay, not fitting into thyroid eye disease. Imaging shows thickening of the extraocular muscle similar to thyroid, but there are some loosened areas within the muscle which is very atypical of thyroid. So we had to go for a biopsy, and biopsy gave the diagnosis of a liposarcoma. So this is where we need step 3 to confirm the diagnosis, to do a biopsy if both step 1 and step 2 is not conclusive. So to summarize, systematic evaluation helps in arriving at the diagnosis. Pandora's box is nothing to be scared about. Pandora's box, in fact, if we listen to the mythological stories of Anurban, was probably not even a Pandora's box. There was nothing evil inside it. But we should remember Pandora to solve the mystery which lies inside the Pandora. So presenting history, absolutely important. Look at the appearance. Inspection gives a lot of findings. Look for any nodules, palpate them, any mass lesion. Detect a bruit if you feel you are dealing with a arteriovenous malformation, AV fistula or malformations. Orbital imaging, which helps to confirm the diagnosis in few cases. And last but not the least, we retrieve some tissue for the biopsy if the other 2 steps fails, and ultimately that's what is going to give us our answer. So thank you very much for your attention.
Thank you so much, ma'am. Definitely thanks for introducing your Pandora concept, and I think a lot of us nearly every day face the mystery of Pandora's box. So I think it's a good Pandora's box. Right. And we move to our next speaker. We have with us Dr. Mritika Sen, and she'll be talking about neoplasias and recognizing the red flag signs. Over to you, Dr. Mritika. And after Dr. Mritika's talk, we will have a small panel discussion, and I'll request Dr. Mritika to join us on the dais after the talk. Thank you.
Good afternoon, everyone. There are some battles that we are forced to witness, but fortunately there are some that we can fight for. So I'll be talking about neoplasias and recognizing the red flags. It is a vast topic because the neoplasia can involve all these structures. So I'll take you through a couple of cases and try to cover the topic. Some of the red flags in every case that we need to look at: the extremes of age group, growth or progression of a condition, duration, as ma'am has already covered, that usually neoplastic lesions progress over a period of weeks or months, laterality and the response to treatment, and check for systemic features as well as palpate the lymph nodes. So coming to the first case, this is a 74-year-old gentleman who was being treated for chronic blepharitis in his right eye for over a year. Now what do we have here? We have thickened lid margin, rounding of the posterior lid margin, as well as loss of the meibomian gland orifices. The lashes are overall intact. When we evert the lid, we see that there is a lesion involving the tarsal surface, and also the lateral canthus with diffuse congestion of the palpebral conjunctiva, and this is definitely not chronic blepharitis. So other things which can be present in sebaceous gland carcinoma are nodular lesion along with the focal loss of lashes and the meibomian gland orifices. Eversion is very important. It can show you intrinsic vascularity, the total extent of the mass. Other than that, congestion of the opposite fornix or the rest of the conjunctiva and a ropey discharge can also indicate possible pagetoid involvement. So red flags for sebaceous gland carcinoma, chronic unilateral blepharitis, chalazion in elderly, as I said, extremes of age group, no response to treatment, and apart from that, the features that we showed in the previous pictures, congestion and ropey discharge, which can lead you to do a map biopsy during the time of biopsy itself. The second case is a 60-year-old male with a reddish-whitish growth over a period of 7 months. Definitely does not look like a pterygium. Why? Because it is nodular with a gelatinous appearance, sessile, overlying keratin, and a feeder vessel with intrinsic vascularity, and it also stains with rose Bengal stain. So OSSN, these are some of the features, and a combination of these is highly sensitive as well as specific for diagnosis of ocular surface squamous neoplasia. So red flags again, apart from what we already saw in the previous pictures, what you need to look at during clinical evaluation is the corneal involvement and scleral fixity. Now this was a 45-year-old female, and she noticed a pigmentation in her right eye only since the last 1 year. Now yes, in Indians we do have complexion associated melanosis, but this has come up only since the last 1 year. So this is primary acquired melanosis, which has these following characteristics. It is asymmetric, seen in middle age group, unilateral with a flat peppery appearance, and unlike a conjunctival nevus, it doesn't have cysts or microfolds. Also the involvement involves the palpebral and the fornicial involvement, which is another sign that you need to possibly go in for a biopsy, and you need to look at the fornices carefully because it can harbor nodularity or a conversion to melanoma. So these are the indications for biopsy: larger lesions, documented progression with thickening of focal thickening or nodularity, presence of feeder vessels and involvement of the cornea. Also, so this was another case that is seen in the images, that this was just a pigmented lesion that the patient noticed over a period of 1 year, but on eversion you can see a thickened lesion involving the entire lid, the palpebral conjunctiva as well as the superior fornix. Conjunctival melanoma itself will be a nodular solid lesion with vascularity and feeder vessels. Coming to the next case, a young male, 26-year-old, sudden onset of conjunctival hemorrhage, and he also noticed a growth recently which was rapidly progressive. So in this case, we don't always have to go ahead with a biopsy. Young patient with a rapidly growing lesion with recurrent subconjunctival hemorrhage, do a systemic evaluation for HIV, and that is Kaposi sarcoma. Now this was a young child actually who came to the oculoplasty department for cosmetic rehabilitation with a thiacical eye. The father gave a history of trauma 3 months back. At that time, when the child was evaluated, there was congestion, posterior synechiae, with the fundus view of the left eye was not visible at all, but the right eye was normal, and she was diagnosed with a prethiacical eye following trauma. But when we asked the history, the father clearly said that the trauma was to the head, not to the eye, and it was an insignificant trauma. So insignificant trauma, clear history of leukocoria 6 months before the onset of trauma, and he also showed old photographs showing an exodeviation. So at that point, ultrasound definitely showed presence of specks of calcification, which was confirmed on MRI, and we went ahead with an enucleation which confirmed the diagnosis of retinoblastoma. So red flags here is leukocoria in a child. It is imperative to rule out retinoblastoma, and before planning any surgical intervention, even if it is for cosmetic purposes, evisceration, ultrasound is essential with or without MRI in cases of doubt. And delayed diagnosis can of course lead to orbital even in thiacical eyes. So these are other lesions which simulate retinoblastoma and present with leukocoria in children. And okay, so this was another child, 6-year-old male, again a history of trauma, and the father noticed a whitish lesion in the eye 15 days post the trauma. This child was being treated as post-traumatic uveitis with vitreous hemorrhage with topical steroids, with secondary glaucoma, so on anti-glaucoma medications and Diamox. But this, if you see, it's a white eye. And does it look like a uveitic kind of a picture? I don't think so. There were multiple seeds studding the whole of the iris, along with 360-degree neovascularization of the iris. And a careful evaluation of the fundus showed a lesion in the inferotemporal location confirmed on ultrasound and on EUA. So this was another case of retinoblastoma in an older child, an anterior form of diffuse infiltrating retinoblastoma. These are the masquerades of retinoblastoma. They can also present with proptosis like an orbital cellulitis, boophthαλmos, thicical eye, vitreous hemorrhage, hyphema, and a white-eyed hypopyon. Now, a 52-year-old diabetic female, sudden onset diminution of vision in the right eye, and she was again referred as a case of vitreous hemorrhage. Now, let's look at this. What is this? It's a dilated episcleral vessel. Along with that, there is focal ectropion uvea and a retrolental pigmented mass. And that showed a ciliocoroidal melanoma. UBM is important in this case to assess the size. So ciliocoroidal melanoma, dilated episcleral vessels, it is very important to look at the periphery carefully, even scleral indentation. Other features which can suggest a ciliocoroidal mass can be presence of correctopia, neovascularization of the ankles and the trabecular meshwork, blood in the angles, ectropion uvea, sectoral cataract and iris heterochromia. Now, choroidal melanoma overall can be of several sizes, but it is important to recognize melanoma, a small melanoma from a nevus. These are basically the imaging characteristics which can help, but I won't go into the details because of time. And finally, coming to the last case, we have a 38-year-old female, and she came with very non-specific complaints of itching, watering, occasional swelling over a period of 6 months. Now, looking at her, there is some amount of ptosis, slight exodeviation of the right eye. But look at her movements. It's restricted in all gazes, in both the eyes. And when we actually palpated her entire orbit, both of them were stiff, with a firm, ill-defined mass palpable in the superotemporal quadrant. MRI showed thickening of all the extraocular muscles along with a dirty orbital ill-defined lesion. Biopsy confirmed a metastatic poorly differentiated carcinoma, and a PET scan showed a multifocal lesion with primary in the breast. Now, when we went back, we asked the patient the history, and she said that she had been noticing mass in both her breasts. Now, sometimes the patient don't give their history, but when the signs don't match the symptoms, we should have a lower threshold for biopsy. So orbit can be the primary manifestation in almost 15 to 53% of the cases of orbital metastasis. And while proptosis is the most common feature, impaired eye motility and ptosis can also be present. And enophthalmos is a sign of Skirrus kind of carcinomas involving the breast and the stomach mainly. So orbital neoplasia, the red flags that we need to be careful about: presence of proptosis, pain, paresthesia, dystopia and movement restriction, raised retrobulbar resistance, and of course corresponding imaging as well as the systemic history is very important. Thank you very much.
Thank you so much, Dr. Mritika. And I would request you to join the panel because we will have a discussion for 3 cases. And I request the Shroff team also to put in their comments and ask questions and rather respond to the questions that I will be asking. So you're most welcome to join. The mic is right here up front. So you can sit up front because it's a panel discussion. Okay. So it's just a basic case discussion, and it would be like, what would you do? Yes, yes. So you'll have to. You asking how much is left? Yeah, we were also given it 1 hour late. So this is the last, just 3 cases, and we are done. We finished 20 minutes early for you. It's a fact. Okay, perfect. So, you see a child over here. This is a 2-year-old, 1.5-year-old child, and who presented to us after some prior treatment, and the treatment the child underwent was incision and drainage, and presented with this picture. And if you can see very closely, there was a small draining sinus. So at this stage, what would you do next? To you, Dr. Mritika.
I think it is important to go ahead with imaging at this stage in a child with a discharging sinus, where we can see that there is some amount of scarring already taking place with lower ectropion.
Right, absolutely. And briefly, the history. So she gave a history that the parents gave a history that at the 6 months of age, so at 6 months of age, the child had started developing swelling. So I asked for old pictures by the parents. As you can see over here, the swelling has started developing, and it was exactly this picture when the patient presented to the previous doctor, and the doctor had tried and attempted a course of antibiotic for 7 days, but there was no change in the picture of the swelling at all. So yes, we absolutely agree that we would go ahead with imaging. But at this stage, again, what would you do next? Like when you know that this was a swelling situation 6 months back, what would you ask for? Like the history part. I would come to the imaging, but again, for the history generation, the patient has come to you with nothing else. But what would you try to look for?
Any history of TB contact or something?
Yes, absolutely. I do agree that you have to ask for a TB history, because most commonly this would be a tubercular osteomyelitis that we are looking at. And as Dr. Mritika asked for, this is the imaging. And as you can see over here on the right hand side, there is a small pocket, and you can see a small cystic lesion. And yes, bony erosion is also present. And on the other side as well, if you go for the other section, there is a bony deformity seen. Again, so now I would ask, what would you do next? What would be your next step?
Probably a biopsy at this stage to confirm the diagnosis, because once they have drained it and we don't have any histopathology from the previous, to send for both the pathology as well as microbiology.
Correct. So we did send for pathology as well as microbiology. Microbiology came out negative for everything. Yes, there was a component of MRSA as well, but histopathology showed no malignant potential, and it showed fibrotic lesion only. And so at this stage, what I would ask you is, what would you do? You have already excised the lesion completely. You have given a broad spectrum antibiotic. We proceeded and we gave another set of antibiotics considering it as MRSA, and even then there was a persistent cyst even after that, and there was not much of a change. What would you say? And you have to convince the pediatrician. So do you think that the pediatrician would get convinced for ATT? What has been your experience about the same?
It's difficult actually, because they require a definitive proof, at least on biopsy or overall a systemic evaluation. If the other tests, I don't know, systemically, if you are suspecting CT TB in a child, whether, because many a times these can be isolated orbital cases also, and you don't get anything systemically. Yeah,
Right.
that is one major problem, that convincing the pediatrician at this stage in such a young child to start ATT.
Right. I absolutely agree. And the point that I was trying to highlight over here is that in such cases, ATT might be just negative. You might, the tubercular tests will be negative. MAN2 was negative, and we even sent quantiferon TB, that was also negative. We have CB-NAT, that is also negative. But at the same time, a broad spectrum antibiotic trial, even if you give, there is a possibility that it is still tubercular osteomyelitis, which should be kept in mind and it should be highlighted. So now another question over here. This is a 45-year-old female who presented to us with a superomedial lesion, as you can see here. And ma'am has very well taught us about the Pandoras that we should be looking out for. So what would you do next, Dr. Seema Das, ma'am?
Step one again.
Yes. from you.
As for the history, duration, associated symptoms, since when it has been, any other, like this is the area which is very close to the sinuses.
Right.
So is it something which is recent onset? Does she have any other symptoms which would suggest something which is secondary to a sinus pathology?
Right, 2 years of history, no other associated symptoms, and this is just the only presentation, no ocular motility restriction as well.
So with the 2-year history, we are probably dealing with something which is more benign. Whether it's a something which is related to the frontoethmoidal sinus coming to the orbit, or something which has been a coexisting lesion. This is also the area where you can have small dermoids. But again, the history is going to be something which is going to be a little longer since childhood or so. So those are the things which needs to be evaluated, and then again the palpation part, which is again going to give you some clue whether you are dealing with a solid lesion or a cystic lesion.
Soft cystic mass.
Yeah, so then possibly the next step would be an imaging. We
Right.
still don't have a diagnosis, it's a differential.
So this is the imaging, and to be more clear, this is
Yeah.
the imaging that showed. Now, what would be your comment, and how would you like to approach this patient?
So going by the imaging findings, the dermoid cannot be ruled out. The content seems to be something where possibly there is fat inside. The other possibility, since she is like older age group, the history is only 2 years. So again, we'd like to go back to the old pictures. Sometimes there are subtle swelling which they don't notice, and we know that dermoids, especially if it's slightly deeper, can become manifest at a little later age group.
Right.
Lipoma probably is the other possibility with these imaging findings. So, but since both of them needs a tissue diagnosis,
Correct.
both for therapeutic as well as diagnostic purpose, the next step would be to go for an
Right.
excision.
So as you rightly said, and since the other segments, other sections of CT which cannot be displayed over here, there was tethering in the bone which indicated towards a more of an orbital dermoid. Now my question is that 45-year-old lady, anterior lesion and an orbital dermoid, how would you like to approach this? Not very economically stable patient.
Surgical approach.
Yeah.
Asking.
Yes, ma'am. Further management.
So this is something which should be amenable to a lid crease incision. We don't know the posterior extent of the lesion. We don't have the axial cuts, so we need to see the posterior extent. But going by the fact that there is not much of proptosis or displacement, you expect the lesion to be localized to the anterior orbit with not much of posterior extension.
So you will prefer to do surgical excision.
Yes.
And ma'am, what's your take on sclerotherapy?
Not at this location. This is something which is slightly deeper inside the orbit.
Right.
Had it been something which is more superficial, lying over a bony base, yes, that would have been a consideration, but not at this location, because we don't want any, inflammation, residual recurrence at this area.
Absolutely. So yes, we proceeded with surgical excision, and the lesion was excised completely, and it was a thin-walled orbital dermoid on histopathology. So I just start these at a third case, but I think our time's up. So thank you everyone for attending the session and being such great audience. Thank you to the panelists and the chairperson for
Thank you,
the
Radhika.
session. Thank you, Dr. Feroz as well.